This is a recording of the January 24th, 2018 webinar from the Institute for Research on Poverty at the University of Wisconsin-Madison on parental substance use, opioid misuse, and child welfare, featuring Annette and Robin Ghertner of the Office of the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services. For more on this topic, please see the link in the description for 2 ASPE research briefs written by a team that includes the presenters. This webinar series is supported as part of the Institute for Research on Poverty's activities as the National Poverty Research Center with support from the Office of the Assistant Secretary for Planning and Evaluation. Robin Ghertner is the first speaker.
My name is Robin Ghertner. I'm the Director of Data and Technical Analysis in our Human Services Policy Office here in the Office of the Assistant Secretary for Planning and Evaluation. I'm here with my colleague,
Annette Waters.
And we are really excited to share this research with you. Just a quick note, the Assistant Secretary for Planning and Evaluation, or ASPE, we're kind of like the policy think tank within the Department of Health and Human Services. We provide all sorts of guidance to the Secretary of HHS as well as different agencies within HHS. So this presentation is the result of a year-long mixed methods study combining some statistical analysis as well as some qualitative interviews and focus groups that has really dug into how the substance use and opioid epidemic has been impacting the child welfare systems across the country. It's part of work done by a much larger team than Annette and myself. The main co-authors are listed on the screen. I also want to thank the research firm Mathematica Policy Research, who we contracted with to conduct the majority of the site visits and qualitative research. They were a remarkable team to work with, and a lot of this information, most of the information we're going to talk about couldn't have been possible without their participation. So I'm going to walk you through a little bit of the background and the context for the study and the findings, and that should illustrate pretty clearly why we did the study and what our goals were. So first, a little bit of background on the National Child Welfare System. The numbers here are just for fiscal year 2015. We have the 2016 data. A lot of it was released recently, so we haven't had a chance to update all of the numbers in this slide deck. So you'll see some numbers for 2016, some numbers for 2015, so we'll try to point out where there may have been where there may be differences. So this is just a snapshot of what the child welfare system nationally looked like in 2015. There were 3.4 million children that were screened in for reports of child maltreatment by state child protective service agencies. Of those 3.4 million, there were 683,000 that had cases that were substantiated, which means upon an investigation, there was found to the children were actually found to be victims of maltreatment. And in 2015, there were just over 269,000 children in foster care. It's not exactly that 269 of the 683,000 because there's some overlap across years, but this kind of gives you a sense of the scope of the child welfare system and the population that we're talking about in particular. Now this slide here gives you a sense of the context. The child welfare system through kind of like the early mid-2000s was seeing declines in the national foster care caseload. This was due to a lot of work nationally at state and local levels to really increase work in reunifying families and trying to lower those caseloads. And there's been a lot of work kind of talking about this. And if those of you who are actual caseworkers or work in the field or providers probably know about that history. But then between 2011 and 2012, those declines started to turn around. And since 2012, we've seen steady increases year to year. And that's caused some concern among many people in the field and observers about why that decline started to turn around. And as the years have been going on, the numbers have been steadily increasing. And the first culprit that has been talked about is substance abuse, and particularly the opioid epidemic. Until a few years ago, there really wasn't a lot of empirical evidence nationwide to really support those, I don't want to call them claims because they are kind of affirmations from caseworkers and providers and policymakers who know what they saw on the ground. But there really wasn't a national picture of what those trends looked like. And that was kind of the impetus for the study that we began. This slide shows the percent of all removals that were due to parental drug abuse. This is a field that states report to the federal government when a child is removed from the home and placed in foster care. They're supposed to report a reason for removal, and among the many options, one of those is parental drug abuse. Now, there are a lot of issues with this data. This is not perfect. States and counties within states report differently. Some report more reliably than others. And we also know that there have been a lot of efforts sponsored by the federal government as well as state and local governments to improve the quality of this data. So the increase could very well be due to changes in reporting practices. But nonetheless, it gives you a little bit of sense of the increase that we see. In 2000, it was reported that only 10% of all foster care entries were due to parental drug abuse. In 2016, that number tripled to 31.3%. A lot of that increase is going to be due to reporting improvements, but regardless, particularly in the past few years where we expect it to be a little more stable, the reporting improvements, rather, we expect them to be more stable, you see kind of pretty big jumps. So this is kind of the context for the problem. So Annette, I'm going to turn it over to you.
So now I'm going to talk about the change in foster care. Okay, so this map shows county-level estimates of the percent change in foster care between 2012 and 2016. So Robin just showed you where the trend line was increasing in the most recent period, and what this map shows you is that the increase is not everywhere. So the dark blue areas of the map are where the foster care caseload actually decreased by 50% during this time period. The medium blue areas of the map are where the foster care caseload decreased up to 50%. And then we start to see the changes. The yellow areas of the map are where the caseload increased up to 15%. The gold areas are where the caseload increased 15 to 30%. And the red areas of the country are where we see the foster care caseload increasing by more than 30% in a 3-year time period. So because IRP is in Wisconsin, what we decided to do is to do a deeper dive into ACF Region 5. That's the Administration on Children and Families. This is their Region 5 areas, and these are the states of Minnesota, Wisconsin, Illinois, Indiana, Ohio, and Michigan. And so what we did was map at the county level what was going on with the caseloads in these states. So we're going to focus on Wisconsin. Wisconsin, there are many counties that saw an increase of more than 30%. In Minnesota, most of their counties saw an increase of more than 30% over this time period. Same thing for Indiana. Less so for Illinois. There's a mixed story in Ohio and a mixed story in Michigan. So things are changing, but not everywhere. So now I want to do a deeper look at changes in prescription opioid sales. So again, we have county level data here. And what we did is we took the distribution in 2016 and applied it backwards. So I call your attention to the legend. The left column of the legend are the actual number of counties, and the right number of the legend are the relative frequencies. So in 2006, 176 counties, or 6% of all U.S. counties, were in the highest category for prescription opioid sales. And then we see as the years go on how prescription opioids spread across the country, and by 2016, I think that's 82 counties, or 25% of all U.S. counties, were in the highest category for prescription opioid sales. So then we decided to do a closer look at Region 5, using the same methodology, taking the distribution in 2016 and applying it backwards. So in Region 5, 18 counties, or 3% of the counties in Region 5, were in the highest category for prescription opioid sales. And then as the years go on, we see how the map gets darker blue. And by 2016, 86% of counties in Region 5, ACF Region 5, were in the highest category for prescription opioid sales. So then what we did is we just looked at the intersection between prescription opioid sales and foster care caseloads. And this data is only for 2016. The light blue areas of the map are where both foster care and opioids are, the dark blue areas are where both foster care and prescription opioid sales are low. The medium blue areas of the map are where opioids are low but foster care is high. The red areas of the map show where both foster care is high and prescription opioids are high. So you can see a geographic story emerging here. And then our next slide is our heat map. So we stripped off all the other colors and we just looked at the counties that had both high prescription opioid sales and high foster care. And so in Appalachia, we see this relationship. We see it in Oklahoma. We see it out west, Northern California. We see it East Coast. Top of Michigan. There are geographic clusterings of these issues. So then we wanted to look at Appalachia specifically because Appalachia has been dealing with an opioid and substance use issue for many, many years. And so what we did, again, this is the reason for removal that Robin talked about, and we looked at the reason for removal in Kentucky, Ohio, Tennessee, and West Virginia from 2000 to 2016. So back in 2000, caseworkers were reporting that not many children were being removed because of parental drug abuse. But as the years go on, we see that all of the trends are moving towards caseworkers checking that box as the reason why children are being removed from the home. And as Robin already said, there's reporting issues and differences, but more caseworkers in 2006 are checking that box than they did in the previous time periods. And then we looked at, again, the counties, this time just for Kentucky, West Virginia, and Tennessee, to look at this relationship. So the red areas of these counties are where opioids are high and foster care is high. In West Virginia, we see a clustering. We see a clustering in eastern Tennessee, in Kentucky. But there are places in these states where opioids are low and foster care is high. So the panhandle of West Virginia, something else is going on there. We can't identify whether it's heroin or any other specific drug because we don't have the data, but we know that something is going on where in those blue areas opioids are low but foster care is still high. So now we're going to look at changes in drug mortality. So we used the same methodology that we did for the opioids map. We took the distribution in 2015 and applied it backwards. So in 2003, 23 U.S. counties, or 1% of all counties, were in the highest category for the volume of morphine equivalent.
Overdose deaths.
Oh, excuse me, overdose deaths. I apologize. For overdose deaths, the highest category for overdose deaths. Now, we can't identify what drug the person died from, but we know that the coroner on that death certificate said the drugs were involved. So in 2003, 23 U.S. counties, or 1%, were in the highest category for drug overdose deaths. And then as the years go on, we see how drug overdose deaths increase in the country. and that by 2015, 774 U.S. counties, or 25% of all U.S. counties, were in the highest category for drug overdose deaths. And then we look at overdose deaths for Region 5. In 2003, there were no counties in the highest category for drug overdose deaths. And then we look at 2007, 2011, 2015, things change. By 2015, 82 counties in Region 5, or 16% of all the counties in Region 5, were in the highest category for drug overdose deaths. And then we look at the relationship between foster care entry rates and drug mortality just for Region 5. And we see the red areas are where drug mortality is high and foster care entries are high. And again, the story is not the same everywhere. You see this geographic clustering in northeastern Michigan. We see what's going on in Indiana. We see what's going on in northern Minnesota. So it's not everywhere, but we do see the relationships in counties. So now I'm going to turn it over to Robin to talk about the mechanisms.
Great. Thanks, Annette. Annette just kind of walked you through a lot of really fascinating descriptive information to kind of get a sense of some of the geographic trends. I want to turn a little bit to some theoretical stuff now to think about, well, how exactly do we expect the child welfare system and caseloads in particular to be impacted by parental substance use. So there's a few ways that this could happen. This is kind of like a nice little flow chart. I hope it's not too complicated to see how the child welfare system is kind of set up. So let me see here. I think there's a way that I can put an arrow on the screen. All right, great. So when we have an instance of parental substance use, to interact with the child welfare system, right, we need some degree of child abuse and neglect, or what we call child maltreatment. That child maltreatment has to be reported by someone. There could be a mandatory reporter, someone in a church, in a hospital, could be neighbors, could be the schools, however that may happen. When the report takes place, then the child welfare system is going to start getting involved. And upon entry of the case, the child welfare investigators or caseworkers could then decide to investigate the claim, and then they may substantiate it. And if it's been substantiated, the court may decide to remove the child and place them, him or her, or them, if it's multiple children, into foster care. Many states have implemented differential response, which is, or alternative response, which is a way to intervene in a case that may not be as severe before an investigation takes place, and provide all sorts of wraparound services. As you can see on the bottom here, the substance use treatment system, we're not going to talk a lot about treatment, but it certainly has a central role here. Substance use treatment providers may be actually the ones making the report. They could be involved upon the substantiation, or they could be part of the differential response, part of the kind of the wraparound services for parents. There should be a line over here, removal as well. It could be part of the case plan for the plan for reunification. And substance use treatment could actually intervene at the beginning of this whole process before maltreatment even takes place. So the mechanisms by which substance use prevalence could lead to more child abuse and neglect is here in the first stage to lead to actually more maltreatment. Or it could be that parental substance use leads to actually more reporting, in that people in the community or mandatory reporters change their reporting behavior because they see so much drugs in the community that they become hypersensitized, and they say, this is too much, we can't stand for this anymore, and they get more aggressive in their reporting behavior. It could be that the child welfare system, caseworkers and providers, are reacting differently. Again, For example, it could be that they also get sensitized to this and say we need to be more aggressive in how we're dealing with cases. Or it could be the courts, actually, or even to the extent that government changes policies. States implement policies to consider maternal substance use as a crime. So these are kind of all different pathways that we could see this theoretical relationship take place, and our study set out to understand that a little bit more. So let me talk you through the methods of our study, how we went about it. The specific objectives that we went out to uncover were to understand how substance use prevalence impacts child welfare caseloads, how it relates to caseloads. And we looked at caseloads in three different ways. We looked at the total reports of child maltreatment, we looked at the reports that were substantiated, and then we looked at foster care entries. Each of these kind of represents different stages in the child welfare, I guess, maybe chain. There are later stages as well, which would be what happens to the children afterwards. Do they reunify with their families? Do we see relinquishment or termination of parental rights, guardianship, adoption, all sorts of other outcomes? This study doesn't look at those specific outcomes. That some later work we are working on now that we expect to maybe come out who knows when. We'll look at that in more detail. And then once we kind of understand how these factors are related, then we really wanted to get on the ground and talk to people in communities to understand how substance use disorder, particularly opioid use disorder, affects child welfare systems, and what agencies, partner organizations, and community factors contribute to this relationship. The design of the study, I'm going to walk through this fairly quickly, but we collected a bunch of administrative data for most counties in the U.S. There was some missing data, and did some statistical analysis. And then we held semi-structured interviews and focus groups with 188 local experts in 11 sites across the country. The people that we interviewed included child welfare administrators and caseworkers. We spoke with judges and other court professionals. We spoke with substance abuse treatment providers and administrators. In some counties, we spoke with officials from public health as well as law enforcement. And these are the places that we went to in the country. We were in Portland, Oregon, Salt Lake City, Santa Fe, Tulsa. We were in southern Mississippi. We went to Johnson City in eastern Tennessee. We went to southern Indiana. In the Oklahoma area, we spoke with some officials from tribes. We were in North Carolina, at several places in West Virginia, and then we were in southern Vermont and eastern Massachusetts. This is a pretty broad swath of the country. The places that we went, we tried to get a variety of geographies. Some of these are urban areas, some of them are rural. They have different demographic makeups, different socioeconomic makeups. They have different kind of histories of child welfare systems. Some are state-run child welfare systems, some are county-run. Some of them have had historical trends of drug abuse. Some, the drug crisis is relatively new. So we tried to really get a variety. Now, even though we're in many places, being a qualitative study, these results shouldn't be taken to be, the statistical results are, but the qualitative results that we're going to discuss shouldn't be taken to be nationally representative. They're perspectives from these specific communities, but because we have a pretty broad geographic diversity of where we went, we feel pretty confident that these results, that we can extrapolate them. But again, don't interpret these as nationally representative. So I'm going to talk through some of the statistical results first, and I guess the two top-line findings are, as you probably would expect from seeing the maps and from what you probably already know from the crisis, that our two measures of substance use prevalence that we used, drug overdose deaths and drug-related hospitalizations, they do correspond to increases in all three child welfare measures. Not only that, though, do we see this positive relationship, which I'll show you in a moment, that substance use prevalence corresponds with more challenging and more severe child welfare cases. And I'm going to show you what I'm talking about in a moment. I should just mention that through the statistical analysis, our intent was the findings that we're presenting are not causal findings, but they do adjust for all sorts of confounding factors that could kind of mar the relationship, make it harder to see what the relationship is, like race, ethnicity, population size, urbanicity, socioeconomic status, specific characteristics of the child welfare system in the states, etc. But without going too much into the methodology, this first chart here shows you the relationship between drug overdose deaths and child welfare case rates. So the way we read this is when we see a 10% increase in drug overdose death rates, so from one year to the next or from one county to the next, a 10% increase in your overdose death rate, we would be predicting that at the same time we would see an increase in reports of child maltreatment by 2.3%, increase in substantiated reports by 2.6%, and an increase in your foster care placement rate of 4.5%. So we see, if you just target on that last bar there, foster care placement, it's almost half as big as that initial, the increase in drug overdose deaths. When we look at drug hospitalizations, and this is any visit to a hospital, being admitted to a hospital or visiting an emergency room, and the diagnosis code is related to some substance, not some non-alcohol substance, but any substance, whether that's heroin or an opioid, cocaine, methamphetamine, a hallucinogen, whatever it may be. The numbers are very similar. They're the effect is a little smaller, or the relationship is a little smaller, but when we see a 10% increase in drug hospitalization rates, we would predict a nearly 2% increase in reports of child maltreatment in that county, a 2.1% increase in substantiated reports, and a 3.3% increase in foster care placements. Now, the first finding is that, yes, there's this positive relationship, which I don't think is surprising to anyone. But what is interesting is, I'm going to go back a slide to look at the drug overdose deaths. It's a little more, it stands out a little more starkly. What you see here is, if you look at those three bars on the right, let me see if I can get my pointer tool up here again. You see these three bars on the right. The height of these bars is increasing, and these bars are statistically different. For those of you who think about statistical significance, these are different. This means that as cases come in the system, if the only thing that an increase in drug overdose deaths did to child welfare was cause more maltreatment, we would expect these bars to all be the same height. That the same number of kids would have their investigation substantiated, and the same number of kids, increase in kids would be removed from the home, or same percentage rather. But what we see is the effect is actually getting bigger, and this suggests two possible explanations. One is that, as I mentioned before, it could be that caseworkers and courts are much more aggressive in removing kids, investigating the claims, substantiating and removing the kids. Alternatively, it could be that these cases are much more complex and severe, where there's more drug abuse. And as Annette will talk through shortly, the evidence on the ground when we were in the 11 sites across the country is that caseworkers and judges all told us that the cases involving parental substance use were particularly in the places that were hardest hit by the opioid crisis, were very complex and difficult to reunify. Annette's going to go into much more detail about kind of what those findings lead to. But this is, for us, this was the an unexpected finding. I guess we kind of expected it from what we heard, but it's a finding that really stands out for us. I'm going to pass it to Annette, and she's going to talk through some of the major findings from our site visits.
So what we did is we took the qualitative results and put them into different buckets. So the first bucket is the scope of the problem. And what we found is that it's not an opioid crisis everywhere. We found that heroin is prevalent, and that in some places methamphetamine is the drug of choice. So again, it's not an opioid crisis everywhere, but we do have a substance use crisis in many, many communities, and we found a lot of polysubstance use. It was pervasive. People were not just on opioids. It might be opioids and heroin, or heroin and meth. And so that was a surprising finding. We also found that it is not just a substance use problem. The parents or the families that come into child welfare come in with a constellation of issues that make these cases more challenging. And we also found that lost economic opportunities and poverty and trauma underlie the current drug epidemic. The next bucket is practice issues. And what we found is that substance use assessment is haphazard. There is not a universal assessment tool that caseworkers can use to identify what substance the parents are even on. And with the legalization of marijuana, now child welfare agencies aren't clear about what to do in terms of marijuana when babies are born exposed to marijuana. If marijuana is legal in a state and mom tests positive, or the baby tests positive at birth for marijuana, how do we handle that? Caseworkers find that differential response is inappropriate for these cases because multi-generational drug use is common. So in cases of differential response, what you'd want is to find some family member a fit family member who's fit and willing to come in and take the child. But substance use is running through families and communities, so it's also more challenging to find somebody in the community who could step in and take the child. And while recognizing the challenges with the ASFA timelines, all of our respondents were very supportive of the ASFA timelines, and Robin is going to go into much more detail about the ASFA timelines coming up. And there are divergent opinions about how good is good enough for reunification. So if mom is not abusing substances but she's on medication-assisted treatment, is that good enough for reunification? If mom is on methadone maintenance, is that good enough for reunification? Or is it necessary for mom to be completely off of all substances and not even taking treatment anymore? But we found on the ground, judges said a variety of things about what they thought was good enough for reunification.
And I just want to, for those of you who don't know, ASFA stands for the Adoption and Safe Families Act, and that sets statutory timelines for when action needs to be taken on a foster care case.
Thank you.
So I'm going to talk a little bit about treatment, and we're doing a little bit of a whirlwind of the findings because there's a lot to go through here. One of the biggest issues that we saw come up in our discussions in the different communities was how substance use treatment, in a particular opioid-specific treatment, and that would be medication-assisted treatment, fits in the child welfare system. And there were a lot of challenges that we saw, and there were a lot of differing perspectives on the way treatment fits in. So I'm going to go through some of the kind of the high points here. The first is that the timeliness of substance use assessments and accessing treatment remains a significant problem in all of the communities that we visited. When a substance use assessment takes place, and Annette talked about this a little bit, when a substance use assessment takes place is not consistent. If the caseworker suspects that parental substance use is a problem, they may order an assessment right away. They may not suspect that substance use is the driver of in large part, child neglect, in lesser cases, actual child abuse. But they may not recognize substance use as a problem until much later down the process, so that the substance use assessment takes place later. And this is a significant problem for a lot of reasons. Knowing what sort of treatment, for one of those areas is knowing when to recommend substance use treatment for the parent, because of all the timelines that I'll get into a moment. That can be present a significant challenge to parents and reunification. Accessing of treatment and when treatment can be available is a giant problem, and especially in the communities that were hardest hit and communities that are in rural areas where treatment is simply less available. The amount of time it may take for a parent to wait to access treatment, to wait to get off the waiting list for a residential treatment program, for example, or to find a slot in a methadone clinic is substantial. And some of the problems we see there comes down to how long the judge is going to be willing to wait before removing the child or ending parental rights. I'll talk about that again in a moment. Communities are experiencing substantial treatment shortages, particularly treatment that is family friendly. A residential inpatient treatment center, for example, may be great for a single adult, but for a mom or a father who's taking care of children, that might not be tenable. The simple shortage of basic treatment, however, is a dramatic problem in many communities. And when we talk about medication-assisted treatment, which is the most effective treatment for opioid use disorder, and it's really the only type of treatment with a strong evidence base of effectiveness, shortages can be devastating. Some of the communities we visited, to access a methadone clinic, for example, an opioid treatment program, parents had to travel halfway across the state. Some of them had to go outside of the state. And for a low-income family, mother or father who's trying in earnest to clean themselves up, to enter recovery, to be able to reunify with their child, this can be devastating. The transportation issues involved in this, the wait list they have to go through, really create a significant barrier to getting treatment and then being able to safely reunify with their children. One thing we found is that child welfare agencies, now this wasn't everyone, but we were seeing it more frequently than we expected, the child welfare agencies are bypassing the quote-unquote regular treatment system. Many of them were paying for treatment themselves, were identifying the substance use providers themselves and paying for it out of their own child welfare funds, or trying to link up with Medicaid to pay for that treatment as well. And this is kind of an indicator of the lack of treatment that's a publicly financed treatment that's made available in a lot of communities, and the desperateness that some of the child welfare agencies that we spoke with, their level of desperation in terms of trying to help families out. The next couple of issues relate very specific to medication-assisted treatment. One of the biggest issues that we saw, and for those of you who work in the field, this probably won't surprise you, there's substantial misunderstanding about what medication-assisted treatment is, what MAT is, how it works, how it relates to child safety. It's not always understood well by practitioners across fields. This is not simply in child welfare systems and in courts, but also within the substance use treatment field. Medication-assisted treatment, which many of you may know what it is. For those of you that don't, it's use of one of three medications FDA-approved medications in conjunction with other sorts of psychosocial supports. Those medications are methadone, buprenorphine, which may go by the trade name Suboxone or Subutex or other names, and naltrexone, which is most common in injectable form, and its trade name is Vivitrol, which you may have seen. So the use of one of these medications in conjunction with different psychosocial supports, it's really where the strongest evidence base is for treatment for opioid use disorder in particular. There is medication-assisted treatment for other substances. Here we're specifically talking about for opioids, and that would include heroin and synthetic opioids. The field doesn't understand exactly how MAT is supposed to work. We often heard confusion, even within the same community, even with the same agency, about whether MAT is appropriate for families, whether it is a legitimate form of treatment, how long a parent should be on and should be enrolled in an MAT program. At what point is it safe for the child to go home while the parent is on MAT? We spoke with caseworkers who swore that MAT is the best, the most effective way to help parents suffering from opioid use disorder, while at the same time the judge in that same community would say, no, we will refuse to reunify a parent if they're on MAT. They have to be completely clean, or they would say, we would hear people discuss, well, they've been on buprenorphine for 6 weeks. What's the problem? Why aren't they off of it by now? When the reality is many people have to be on MAT for a long time. So that's just a taste of kind of the lack of understanding of perceptions, but there's also it's not quite understood yet. There aren't yet standards about how MAT should fit in child welfare. As I mentioned before, the availability of MAT is limited and it's frequently implemented in ways not consistent with evidence-based practices. This is particularly true in rural areas where a lot of the psychosocial supports do not exist. So you may have a buprenorphine clinic, could be done by a primary care physician who is certified to distribute buprenorphine, but there may be no other services that the patient can partake in. So they're simply taking buprenorphine, and while they're at a low risk of drug overdose and they may have lower cravings, they're not getting the other sorts of treatment that can actually deal with their addiction problem. MAT drugs, in this case methadone and buprenorphine, naltrexone doesn't fit in this, are widely perceived to be at risk of abuse and diversion. And these are perceptions. I want to emphasize all these qualitative findings are based off of discussions we had. But in some places, child welfare officials and practitioners told us that they thought that buprenorphine was the primary drug of abuse. Now, it is possible to abuse buprenorphine, but I'm not going to go into all the details about how it interacts with opioid receptors and everything, but it's not, you don't get the same high as you get from other drugs. But there are lots of concerns among caseworkers and judges. Their perception is that it's still commonly believed that they're just replacing one drug for another, despite the evidence base that these are the most effective ways to get off of, to deal with opioid use disorder. And the last point I want to talk about here is how the treatment timelines don't always align with child welfare timelines. And I just want to illustrate this briefly, what I mean here. We've got the top arrow here gives us we have the child welfare timelines that caseworkers and courts have to deal with from ASFA. That in a specific time period, children have to be placed in a permanent, safe place. Then we have treatment problems, accessing treatment. There has to be an open slot in the treatment program. In many states, Medicaid will cover buprenorphine, but you may have to get pre-approval, and that could take time. Your insurance may not approve you for treatment right away. And then there are limits to capacity. Over on the left, we see the actual decision by the parent to seek treatment. Individuals that suffer from addiction, they go through a window of opportunity where they realize that they need treatment and they may go seek treatment. But when that aligns with the access to treatment, the availability of treatment, they may not align. So when they go and make that phone call, I'm ready for treatment, if there isn't an open slot, then that's a missed opportunity for them. And then the last, but probably the most important, is child development. Childhood is short, and this is kind of the root of the ASFA timeline. Every day, every week, every month counts in that child's development. I'm going to pass it over to Annette.
So we also found in our attitudes and collaboration bucket that there were barriers to child welfare and substance use treatment programs collaborating, and they have a difficult time often working with each other. We also found a lot of pessimism about opportunities for successful family reunification. Child welfare was pessimistic. The courts were pessimistic. Substance use treatment providers were pessimistic because they were seeing such severity. The severity of cases was just different than it had been in the past. And cross-state issues abound. Border states who have different child welfare systems and laws and treatment providers, how can they communicate and work together across these state boundaries on behalf of families? Our next bucket was child welfare resource issues. Agencies and caseworkers are overwhelmed. There are, as Robin already said, more cases coming into the system, but more complicated cases that caseworkers are dealing with. Child welfare staff are also working in increasingly dangerous situations, and they fear for their physical safety in doing this kind of work. And there are dangers of coming in contact with illicit drugs like crystal meth while conducting home visits. And the caseworkers said that there were intensifying shortages of foster homes because there were so many drugs in the community. But there are opportunities for improvement. And the first is to have a better assessment tools for substance use in child welfare. Also, as Robin said, we must expand treatment access and include a strong referral process and ongoing case consultation between the systems to drive decision-making on behalf of parents. And somehow we have to work toward building consensus across the stakeholders, across the systems, regarding the milestones required for reunification when parents are participating in substance use treatment programs. And there was a call to share data across the system so that resources could be more targeted. Also, the people we talked with wanted to promote and support partnerships between substance use treatment providers and child welfare agencies in order to establish standards of care for child welfare-involved families. Increased education outreach on medication-assisted treatment, targeting different stakeholder groups so that everybody has the same understanding about MAT and how it works and what its benefits are. And to develop standards for MAT in the child welfare context, including counseling and recovery supports to reports related to family and parenting issues. And we also heard a lot about the usefulness of family drug courts. And in communities that don't have family drug courts, how to incorporate some of those best practices in family drug courts into regular courts and conventional family courts. Also, to improve the ability of home visiting programs to interface with substance use treatment agencies on behalf of parents.
Great. So I want to thank you all for listening. We kind of gave you a whirlwind of issues